I thought I'd illustrate quickly with this is a history of a real patient from many years ago, 60-year-old chap who came through our unit from up north. His son was a GP. He originally came from India. Language difficulties in terms of the patient didn't speak much English. As always, we doctors just don't know why this happens, but complicated transfers only happen immediately before public holidays. It's guaranteed. New Year's Eve transfer. He'd been in another hospital for 6 months, and he'd been in the Radcliffe Infirmary when it was still open for 2 months, but nevertheless New Year's Eve is when he came to us. And he'd been under the neurosurgeons and the diabetologists. He'd had a whole range of complicated medical problems prior to that, including prostatic disease, renal failure. He was on steroids, he was diabetic. Someone had treated him for tuberculosis, just in case. Well, not too surprisingly, his liver had become inflamed due to the tuberculosis. His bone marrow packed up, probably because of a combination of the events above. For good measure, he now had Parkinson's disease. This is not his picture, but this is pretty much what he looked like when he came across, with this enormous bend in his spine, and he also had an abnormality in his hip. And the images showed that both his hip joint and his spine appeared to be dissolving. He was in considerable misery, not really surprisingly, given what this poor chap had gone through. He was unable to walk and in a lot of pain. His initial assessment was by our senior house officer, and we had our current house officer at the back there. He was reviewed then by an infectious diseases registrar. 2 consultants came in to review him. A pain team consultant came to review him. A radiologist was then involved, so I can't recall, it may have been Mr. Fairbank and Dr. Wilson at the back there. I don't remember, it's quite 10 years ago now. He was given pain relief with morphine. He was seen by a physiotherapist and a dietitian. There was multidisciplinary team planning during our weekly meeting and during the X-ray meeting. And we decided that, not unreasonably, we ought to try and establish a diagnosis. We had a very high index of suspicion that this was going to be a very unusual infection in a patient whose immune system was not normal. And the question we were asking ourselves was, is the thigh bone connected to the backbone? Well, in bone infection, of course, the 2 things usually are connected. So he had a biopsy performed. I think this is a spinal biopsy performed, which unfortunately did not grow anything. He had increasing hip pain, and it was decided to remove his native hip joint. And a fungus, and this is a picture under the microscope of a fungus called aspergillus, which is a fungus that occurs in the environment that's in the room. Okay? It occurs everywhere. It doesn't really bother us unless you're immunosuppressed. So this poor chap, because of his immunosuppression, had a fungal infection involving his spine and his hip joint with this organism, which is deadly, even though it looks beautiful in this imaging. We started him on an antifungal drug called amphotericin B for 1 month. I would point out that 10 years ago, that was £250 a day just for the medication, and that's the NHS wholesale cost. I don't know what it costs now. So that's £7,500 purely of antibiotic cost. And I think this is Dr. Wilson at the back there probably injected his spine to stabilize his spine to give pain relief. We then put him onto a tablet antifungal drug for a further 4 months at a cost of almost £2,000 a month 10 years ago, so it was another £8,000 worth of antibiotics. And 5 months after he arrived, he was walking again with a frame, and he was transferred back to Warwick for rehabilitation. And then he put on weight, and 6 months later he came back to us to have his hip joint reconstructed, which he had successfully reconstructed. And eventually he walked with a straight spine, pain-free and infection-free. Now, why did I tell this story at all? Because this chap was a middle-aged man. He didn't come from Oxford. He had numerous illnesses. He was depressed. He'd been in bed for a long time. Multiple hospitals were involved, both in Oxford and outside of Oxford. He had multiple surgical procedures, 13 months in hospital, lots of different colleagues involved. And really the only point I'm trying to make is that for this man to be treatable at all, never mind curable, you really have to have a specialist bone infection service. We estimate that this unit here probably sees something like 15% of the United Kingdom's bone infection. 15%. We really don't know where people go if they're outside of Oxford. There is no other dedicated bone infection unit in the country. In fact, there's no other dedicated bone infection unit in the world. It's the only organisation of its kind. And yes, for the last slide related to this chap, yes, we do believe the thigh bone is connected to the backbone. It was the same infection, tends to spread through the bloodstream, and in this particular gentleman's case, had seeded both to his hip and to his spine. Now, the bone infection unit up here is a 26-bedded ward. It's mostly side rooms. It's got some 4-bedded bays. I can't decide whether I like bays or side rooms. I sort of recognise some of you guys here as the patients. Who likes being in a bay? So, who prefers a side room? I must say, I much prefer a side room, but we do have some patients who actually like to socialise, and they much prefer being in the bay. But I have to say, if you know, given the choice of being half butt naked, I'd much rather do it in the side room than be in the bay. Historically, the bone infection unit has been present for some time. These are some pictures of patients. This just shows you how the disease process that is bone infection has changed. These are patients predominantly with tuberculosis, where it was felt that the really important thing was to put them out in the sunlight, and that would help the bone infection. Well, actually, sunlight does kill the TB germ, but unfortunately, that's only if the sunlight can get on the germ. So if it's in your bones, it isn't going to do a lot of good. However, what the sunlight would have done is it would have helped with vitamin D metabolism and bone strengthening. So there probably was some benefit from that. There's a picture of Girdleston, probably looking for parking, so nothing's changed. But seriously, that is a picture of Girdleston. That is a picture of Girdleston. I don't know why he's walking a donkey around. As everyone knows, his house used to be just across the road and is now accommodation for staff, and he's famous for the Girdleston procedure, which is the excision of the proximal third or thereabouts of the femur for infection, and left with nothing, basically, which is a remarkably successful operation. Okay? If the goal was an infection-free, mostly functional joint, then that achieved it. Okay? So he's a man who used to work here. Now, just to illustrate some of the sorts of infections that come through our service, the chap at the top there was referred by his GP. I think he was in his 90s, and my colleague Tony Berent actually saw him. He was in his 90s, and he'd had that for 50 years. And he said, I don't want to be here, my GP sent me here. And in fact, there really was no reason for him to be up here, but his GP had sent him up saying, well, I think you better have something done about this. But he'd been shot through the arm during the war, and he'd had an infection in his bone ever since then. So chronicity is one of the hallmarks of bone infection. It just persists and persists and persists and doesn't go away. The chap on the right, I think, had a fight on Friday night, and he's fractured that his finger there. It's been pinned. You can see those wires pinning the fracture together, and it's subsequently become infected. And then we've got another typical infection of an ulcer there, which I think is over an ankle joint. Mr. Sharp and Mr. Cook often have to deal with that. We use a lot of imaging to look for spinal infection. The hallmark often of these prosthetic devices when they become infection, the hallmark is pain for a long time, and then a little bit of pus oozing out of a sinus typically, which may look as innocent, okay, but that doesn't mean not painful, as innocent as that top right-hand slide. And then there's a picture, or an x-ray there of an artificial knee joint, which is another area of business for us.